have 20 years of DSO management experience. So in that 20 years, I've been very fortunate to be around some of the greatest influencers and educators, and been very blessed to learn a lot in the industry. It is mainly my only resume. Since I was 15, I worked in a DSO in Michigan and then carried it on with Dental One Partners and North American Dental Group, and now I have my own. So I'm very blessed in that fashion to have always been a DSO guru here. So, and if anything I learned, we go through different trial and error through different processes and systems, but the one thing that I'm confident and will stand by is creating these clinical foundations for your DSO is very critical to the business, and it will prove over and over again to work. Some of our course objectives that we're going to cover today is comprehensive care, periodontal guidelines, regulatory guidelines, the business of hygiene, standard operating procedures, metrics for best practices, and monthly profit and loss. So where do we start? So doctor owners, define your plan. What is your plan? So it's important that the doctor owners or the doctors, whether it's a DSO of 100 locations, 200 locations, or one location, what is your philosophy? What do you firmly believe in, and how do you envision your clinical department to be managed and ran? What are some of your beliefs in leadership? For me, I have, a couple philosophies of like, I would never ask anyone to do anything that I wouldn't do or have not done. So I always keep that in the back of my head. I've practiced servant leadership for the last decade. I've created mission statements, core values, and a vision for, not only my organization, but then you can also do it per department. So it's important that the doctor owners have that in place prior to picking your people. So once you have your people, though, then you can collaborate and elaborate more on your vision, your mission statement, and your core values, and include them in that final vision for your organization. So when identifying the best fit hygienist, it is important to get the right-minded hygienist on board. Are they just there to clock in and clock out? Or are they very passionate for the field of dentistry, for their patients? So that's something that you have to assess and make sure that they share the same clinical philosophies as well. Systems. We'll talk further into what are some different systems, some different foundations that, and Rachel alluded to, pillars. What are the pillars of your organization that we would want to implement to get the best clinical foundation for your organization? Training and development. It's important to also, when thinking about your training and development area of expertise, the person that you pick, that you choose to lead your organization, to lead your hygiene department, and I keep saying organization and coming back to, we're here to talk about hygiene and growing the hygiene department. So when you pick that person to help take your hygienist from tooth cleaners to periodontal therapists, to give them that paradigm shift of thinking, ensure that that person that you are choosing to help lead, train, develop your teams is a people person, someone they can relate to, someone that's approachable, someone that has been in their shoes is very important as well. And then holding accountability. So we will get to more of the systems and accountability as we go through the program. So what are some of the key relationships when you are creating your systems? Who is going to be affected by these systems? Ultimately and always, your patients are at the forefront of any programs you're implementing. How can we give the patients the best possible experience? How can we make them feel so important and so valued? Also your teams, and we're not just talking about your dental hygienists or your hygiene assistants, we're talking about everybody from the front to the back. Everyone who touches that patient, whether they're a sterilizing assistant or they're your doctor partner, those teams, everybody matters. Every relationship is meaningful. Associate doctors getting their buy-in, partner doctors getting their buy-in, ensuring that when we are creating these systems, these protocols, these guidelines, we know that it's affecting our patients, but it's also affecting our teams and our doctors. And we need to ensure that everybody is sharing in that vision. Comprehensive care. So after you've identified your team members, right, and you're setting your systems now, let's dive into comprehensive care, okay? So this all just supports everything that Rachel just went over. So it was amazing that we didn't even see each other's presentations, but it ended up being so collaborative. So it's awesome to see that great, people have the same mindset around you. So that's awesome. Thank you, Rachel. So comprehensive care, treatment planning our patients, always looking at, of course, ultimately your oral disease, their oral disease, but also their medical disease, so that we are giving them one treatment plan that encompasses their total overall health. What are some benefits to a comprehensive exam? And this is all according to the ADA. So in the past, we've always done episodic, there's been a lot of doctors that just do episodic care, limited exam, or taking one PA. But what are the benefits to a comprehensive exam? What do we benefit from that? So we go on to creating a condition-based exam. And you have different parameters that encompass that exam. The more facts that we can gather and the more data that we can give to our patients is so much, it's critical to their treatment plan acceptance. That's where they take ownership of their treatment plan. And that approach has been proven to work over and over versus the limited focus of a limited exam. Okay, what are some of the parameters of a comprehensive exam? So these can be many. I've chosen the few that I feel are few that I've been using for years. You can have fewer than these and you can have much more. But for me, these are the parameters that I have felt have been extremely important to what I call a basic exam, actually. So medical history, a thorough review of the medications, and their systemic links, just as Rachel discussed earlier, is important. Blood pressures, taking blood pressures on your patients every visit. If you have a couple false readings, it's important to have, a manual cuff and stethoscope ready so that you can take a manual reading. What necessary radiographs? And again, this is all from the doctor owner, the doctor partners. They all need to collaborate on what they feel are their parameters of a comprehensive exam. What necessary x-rays? So I've been fortunate that my doctor partners have always believed in 21 years and older of getting a full mouth series of x-rays. Doctors can only diagnose what they see. So if they can't see, how can they diagnose? Intraoral camera. Those images are huge. I mean, what patients see, that saying, picture's worth 1,000 words, it's so true. Now there's so many high-tech scanners that show images and use those as well. Getting a shade at the beginning, it just opens up a whole conversation about whitening, everything from whitening, veneers, crowns, what have you. It's just an amazing segue into cosmetic care. Intraoral and extraoral exam. If you have the luxury of having a screening device, that's amazing, use that. But if you don't, always ensure that you're doing a hard and soft tissue exam, and you're also letting the patient know that you are doing the exam. The worst thing is when you're doing it every ReCare and the patient doesn't know that you're doing it and you're not talking about it, and then the doctor comes in one day and does it, and the patient's like, "Oh, I've never had that done before," and I'm like, I do it every visit. What are you talking about? But because I never said that I'm doing it, so the patient didn't know, and so it wasn't adding any value. So it is important to always talk about what you're doing and add value to your appointment. Full mouth periodontal charting. Are you just going in and charting and documenting the numbers, or are you elaborating on what you're doing? I've always taken my perio chart or my perio book of charting, of showing the different stages of periodontal disease, placing it on the patient's lap and letting them know, like, this is what we're going to be doing. Before I even start perio charting, I would say, I'm going to go ahead and take an assessment. I'm going to measure the space between your gums and your teeth. Anything 0 to 3 is normal. Anything more than that, we need to assess to see what type of cleaning you qualify for. It kind of just sets the stage to let them know that it may not be a normal cleaning. It may be something more entailed. If you have a hygiene assistant, it's always make sure they're in the room when you're doing the periodontal charting. If you don't have a hygiene assistant and it's someone that you know is going to need more, more thorough cleaning, then make sure you bring someone in and do the overhear psychology. Or if you're doing it alone, call out the numbers out loud. Diagnosis and prognosis. So let's talk about that. So a lot of times, we know our doctors are diagnosing, but are they ever prognosing as well, or documenting the prognosis? Are we letting the patients know what the prognosis is? What are the ramifications of them not treating the disease? What are the ramifications of them not following through with the root canal therapy? So that's a critical part of the comprehensive exam as well. So if you are using templates for your exam, include the diagnosis and prognosis so that it trains the doctors and hygienists to, put something in there. Make sure that they're discussing it with the patient and documenting it. If you're referring to a specialist outside of the network, always make sure you're following up. Detailed documentation is critical to compliance and critical to knowing what's going on with your patient. And it's important, if you're referring them out for a biopsy, a lesion, what have you, you need to follow up with those patients and make sure you're documenting. Financial arrangement forms is critical as well. On all treatment plans, even if you're in a Medicaid environment and your patients are 100% covered on that treatment plan, it's important to get their signature that they are consenting to this. It's not so much a consent form, but it's a consent to bill their insurance, right? So now, one thing to remember, everyone, is you cannot create periodontal guidelines until you have created comprehensive care guidelines. You have to have the comprehensive care first, because periodontal guidelines are just a sub-guideline to your comprehensive care guidelines. So it's just a subsection of your comp care. And when you are forming your guidelines, always take what the ADA has come up with, what the AAP has come up with, and then continually update them annually according to the CDT updates. And if you're a believer in evidence-based dentistry, you want to include all of those studies as well. So we won't get into detail too much with the staging and grading, but it came out in 2019, as Rachel has already discussed, and it just confirms the importance of full mouth periodontal charting and the review of medical history. The 2019 periodontitis guidelines included tobacco and diabetes, which is important because of the fact that it's incorporating more and more of the health of the patient, the medical history. So it's adding value to what we're doing on a daily basis. So as we discussed, we've identified our people. We identified the importance of clinical comprehensive care. We've identified periodontal guidelines and how important that is to the foundation of our clinical platforms. Let's talk about some more clinical systems that could be potentially put into place. We're also going to talk about some administrative platforms as well. So COVID-19 infection control, I know we've always had OSHA, infection control, CDC in the past, but I think it's so much more important now to ensure that we're putting them in writing and getting sign off by the team member. So it's changed for us, right? So we need to make sure everyone's wearing, you know, their N95 masks or their KN95 masks. What is the armamentarium for them? What is the PPE that we're supplying, and how do we want that used? Again, we do have Ohio State Dental Board regulations. We have ADA regulations. Also, doctor owners, what is your regulation? Incorporate that into your infection control program and make that mandatory and have the team members sign off. Supply formulary. Many of you have supply formularies in place, but in order for you to scale up comfortably, uniformly, and always remember that these platforms, you're creating them to not only become scalable, but measurable and replicable. So that you may be wanting to open one practice, or you may be wanting to open 10 practices in a quarter. I don't know, but whatever it is, you need to be organized for that growth. You never know what comes on the market. Supply formulary for hygiene is creating, you know, what are the tools and supplies and instruments that you want your hygienist to be using? What is the collaboration from, you know, giving the hygienist a survey? Pick the top, you know, 10 scalers that they want in their formulary. What products do they want in their formulary? And not only that, if you're planning on doing a build out or a remodel or a de novo and adding more locations, what does that look like? What kind of chairs will you be ordering? What type of lights? What type of TV screens? So all of this, you know, starts to add up. And if you're a small DSO and you're looking to, you know, grow, whether you're growing fast or you're growing slow, it doesn't matter. You just need to be organized with that. So it makes it a lot easier so that you can always have that at your fingertips. Products and whitening should be incorporated into your periodontal guidelines as well. Quality assurance, we'll dive deeper into that later through the program. Administrative standard operating procedures. So I'm just naming a few of the top ones that I felt like we had enough time to discuss. New patient flow, ReCare patients, confirmations, insurance breakdowns, and claims, to name again a few. So let's talk a little bit about new patient flow. It's critical for the doctor owner to define how they want their new patients to flow through the practice. So the doctors and hygienists, they can collaborate on that and ultimately come up with one new patient flow. Will they be flowing through hygiene, or will they be flowing through general? Whatever scenario that is, make sure everything that you want in that new patient visit is uniform and streamlined, and it is being done across the board. The worst thing is when you have two new patients come in, husband and wife, two different last names. One gets a periodontal chart, one doesn't. One gets an oral cancer screening, the other doesn't. And then they collaborate about it after their appointment and find out that somebody was cheated off of two added value procedures that weren't done on them. So, and that's happened. That's a live scenario of what's happened under, my management in the past. So it's extremely important that every new patient is treated the same. ReCare patients as well. What type of x-rays do the doctors want on the ReCare patients? How do they want the ReCare patients treated? Do they want full mouth 6-point probe on every ReCare patient every visit? That's an important standard operating procedure. Confirmations. Are you using an automated system such as Sesame, or Sesame is what we use, but it's like Solution Reach. There's just so many out there these days. But are you using an automated system? And if you do, what happens at the end of the day when there's still 20 patients that haven't been confirmed? They haven't replied. Whose job is it to call those patients? Do you have an operating procedure in place? Who can you hold accountable for that, right? So going back to, the first slide that we had was, you have the people, you have the systems, you have the training, and then the accountability. Well, you can't hold anyone accountable if you don't have a procedure in place and you haven't properly trained them on that procedure. So I think there was a question recently asked in Rachel's presentation about accountability. Well, it all comes down to did you have a protocol? Did you provide the correct training? Was everybody's job descriptions clear on what the expectations were? Then you can hold that accountability. Insurance breakdowns. What is your process currently? Are they doing it annually? Are they doing it biannually? Do they do it every time the patient comes in? For Medicaid, you better be doing it every time the patient comes in. For the non-Medicaid practices, at least every ReCare. What is the process? What information are you actually gathering from the insurance company that's being input into the system so that your hygienist and your doctors have an idea of the treatment plan or your treatment coordinator? So insurance breakdowns is a big confidence booster for hygienists. Now, we're never treatment planning according to insurance, but let's be realistic. This day and age, like we talked about with COVID-19 and everything going on in the world with this global pandemic, a lot of patients either A, have lost their insurance or it's been downgraded, or they're on state-funded plans, or they're watching every penny, so they need to know what is their out-of-pocket cost. So it's very important that we have these breakdowns not only in the system, but accurate. And also a confident booster for the hygienist. How awesome and how amazing is it when you know that before you see your patients, before huddle, when you're mapping out your day, and you know that 3 of your 10 patients have fluoride coverage, and they've needed it, and why haven't I told them before? That their perio non-surgical periodontal treatment is covered at 80%. Their localized antimicrobial agent is covered at a percentage. It's such a confidence booster when you know that you're going to be able to give that patient the treatment they need and they deserve, and that is going to be covered, by their insurance. Claims. Are we just randomly sending the claims out, waiting for them to hit the clearinghouse and be pushed back and asking for more attachments or, narratives? Why would we do that? It's just a waste of time, waste of money. It's causing a delay in the doctor's pay. Most doctors get paid on collections, so it's important for them to ensure they're doing the work. So now it's our responsibility to get those claims sent out clean and thorough. So why are we talking about this on a hygiene call? Because it's the same for your hygienist. Like, you want to ensure your patients, you're telling the patients, our your copay's 20%, your insurance is going to cover X amount of dollars. You want to make sure that claim is going out for that patient that has the necessary x-rays, has the periodontal charting, has the narrative that's discussing why that patient needed non-surgical periodontal therapy. So if we do it on the front end and we're doing it properly, then we'll get our collections in a timely fashion, and that patient will be squared away on their bill when they get their statement. Those are important factors to creating that ultimate patient experience. And that is what our goals should all be, is making sure that we're streamlining, making everything uniform, and creating that amazing experience for our patients. New patient paperwork. Do we have that uniform throughout the organization? Are all the new patients filling out the same paperwork? Are the doctors signing in the right location, in the same locations? When you're in a DSO, you have doctors that sometimes travel to other practices. You have hygienists traveling to other practices and other team members. You want to make sure they're entering into a comfortable, familiar environment. When things of this nature, of these administrative guidelines and clinical guidelines, are disarray and everybody's operating on a different playing field, it makes for an uncomfortable dynamic change for that doctor to go step into the shoes of another doctor in another location, or the hygienist, or dental assistant. So it's important that you have that uniform paperwork. And if you're doing acquisitions, most of the time when you're acquiring, the practices that you're acquiring don't have a good new patient paperwork protocol or program or medical history. I remember acquiring a practice that they hadn't updated the medical history in 12 years. So it's important that you get everybody refreshed up, new patient paperwork, all uniform, medical histories inputted and organized. As well as when you're with the new patient paperwork, two of the important things are cell phones and emails, because that's how the automated confirmations are contacting your patients. So it's important that we're updating that information, not only with the new patient paperwork, but then every time they come in. Simple question. Is your email still aziza.abed5@gmail? Is your cell phone number still 440-829-4628? You know, things like that. So those are important pieces that should be part of a platform. Consent forms. Do you have one consent form that has all of the different treatments that could potentially be rendered in your practice, where the patient has to initial, or do you have different multiple consent forms on different procedures? Whatever process you have in place, just make sure, again, it's uniform throughout your entire organization and everybody's following the same procedure and everyone understands the importance of getting those consent forms signed and input into the patient record. Scheduling templates, we could probably talk 2 hours on this subject. Unfortunately, today we don't have 2 hours, and with my slow movement of the slides, we'll barely be lucky to fit in my hour of time. But scheduling templates, the important takeaway from that today is to ensure that you're reserving slots for new patients and for your scaling and route planning. As we discussed with the comp exam and periodontal charting, you're putting that emphasis on the treatment, you're putting the emphasis on the scaling, you know, non-surgical periodontal therapy, but then you're telling the patient, oh, well, you know what, we can't get you in for like 2 weeks or 3 weeks. So how does that make that patient feel? You know, new patients, how long is it taking them to get into the schedule? So in my history of management, if that patient has to wait, you know, more than a couple days, they're going to hang up and call someone else. And nowadays with the millennials, if they did wake up at one morning and decide they want a cleaning, they want to be seen today. They don't even want to wait until 2 days. So it's important that you're thinking of all of these things. And again, we could spend a whole, you know, couple hours just on scheduling templates and kind of like, you know, building them around your providers, you know, and their time management and on your patient demographics and what's happening in that particular office or offices. Now, scheduling templates sometimes cannot be uniform throughout an organization. A lot of times they have to be specific to the provider. If you have a new doctor or a new hygienist right out of school, they can't operate at a scheduling template of a tenured doctor of 10 plus years. So it's important to build those around the provider and customize them accordingly. Also, you want to customize them according to your new patient flow in your practice, how much perio percent in your practice, so that you're not having any wasted time slots. But at the same time, you have to have a standard operating procedure around it. So if you are reserving these new patient slots or you are reserving the perio slots, what is the time factor that you're going to allow anything to go in there versus reserving them? So is it a 24-hour rule? Is it a 48-hour rule? So that all needs to be mapped out and defined. Again, it is important, just like we talked in the slide before, with defining your plan. These are all things that need to be included in that plan, right? So you need to think about all these different factors and variables that come into play with all of these different platforms. I want to elaborate a little bit more on the parameters of comprehensive care. So if your new patients are going through hygiene and the hygienist is basically doing the majority of these assessments and gathering the data for the doctor, it's critical that the hygienist is also talking about the different things that he or she is seeing. Because when the patient hears it from the hygienist and then hears it from the doctor, when the doctor has made diagnosis, it just brings more to life to what's really going on with that patient. So it's important that the hygienist, now we're never allowed to diagnose, as we all know, but we're allowed to talk, we're allowed to discuss, we're allowed to say what we see, correct? And it is my advice to everyone on the call that if you are a hygienist or if you are a doctor owner or a doctor partner or an associate doc, get together with your hygienist and kind of like sit down and go through x-rays, go through different FMXs, different Panorexes, and talk about what they should be seeing and what they should be talking about, and what is your comfort level as a doctor that you feel comfortable with your hygienist discussing with your patients. What do you want them to talk about? If they see a broken tooth, are they allowed to say, oh, I see your tooth is broken. Most of the time, Dr. Peach likes to put a crown on this tooth, you know, so on and so forth. If you have a large filling, you say, oh, are any of these sensitive as you're going through and probing? And the patient says, well, should I be sensitive? What's going on there? Well, they're really large restorations, and, you know, most of the time, the doctor recommends, you know, to crown these teeth with large fillings so that it acts as a helmet to protect against breaking, you know, and, you know, just different things like that. But I firmly recommend that you get together with your doctor and have a discussion around the comfort zone for assessing patients. So with the staging and grading that Rachel reviewed very thoroughly, thank you, Rachel, again. What I did was kind of make it very simple, try to simplify it as much as possible for our hygienists to be able to use it as a narrative. It's a lot of documentation, right? A lot of documentation going into progress notes, and depending on your time schedule, you may not have, you know, too much time during that visit to put everything in there. But how nice is this that you just get a form, put patient name, doctor name, hygienist name, and circle. Just circle the stage that is most applicable to your patient, and circle the grade that's most applicable. And then at the bottom, just kind of circle what kind of treatment plan you're doing. You know, again, it's just a narrative to add some color to the claim. And then also it's kind of cut off here, but there's a notes section as well where you could just jot down some notes. Kind of always try to reflect back to the medical history, to the periodontal charting, to the patient habits, maybe some oral habits, things of that nature that will help to show the auditor of the insurance company that this is something that should move forward and get paid. For those of you who have Medicaid practices, it is important that you attach this as well. Medicaid is paying for the 4342s, 4341s, more so than they've been in the past. At least that's what I'm recognizing. So, but it's important, again, to attach the necessary radiographs, the full mouth periodontal charting, and the narrative. And this is just a simple way to create a narrative. So everyone knows how hygienists, we're very black and white. You tell us which way to run, and we're going to run, and we're going to run as fast as we can. We're very organized. We're very diligent in our work. We want to make sure we get every piece of tartar off. We don't like mess. We don't like chaos. We don't like drama. And for that reason, taking the AAP 2019 guidelines, doing the staging and grading is great. We've got that down, but now we need more clarification. How do we dive down into the treatment plan that we want to put? What CDT codes do we want to use? What follow-up treatment do we want, right? So I've been using this chart, this graph, introduced to me years ago, 15 years ago, and been using it for that long, and it's just simple. It's just very easy. Again, doctor partners and your hygienists and doctors need to collaborate on your own standard treatment plan, or your standard perio treatment assessment for, your protocol for your hygienist to be using. But this is just a sample of what we're using at Pure Health, and it's just very simple, just kind of outlining the periodontal classifications, what are the characteristics, what ADA codes would the hygienist be using, and then what is the definition of that treatment, and then what is the follow-through. And again, I have incorporated my products into the treatment, into the guideline, into the periodontal guideline, for the reason that it's important for them to, again, hygienists like clarity. They like to have organization, and it's just a very organized manner to incorporate your products into the treatment plan. And I've been using the Floridex products back when it was, belonging to, I think it was Discus Dental was the first owners of it. So it may have changed names, it may have changed vendor delivery, but it's not changed the product. And that's what I love about these products for take-home care. So let's talk a little bit about one of the scenarios. So let's say you have a patient has isolated 4mm pockets. Now, the important factor between the chronic perial slight and the slide before that, so this one has bone loss, and then the one before that, you can have 4mm pockets with no bone loss, and that's the 43-46 scaling in the presence of periodontal of generalized gingivitis. Right, so the differentiation is the bone loss, and it is very important when you are treatment planning patients that do have insurance, because insurance does look at this. So, let's just talk about this scenario where there is radiographic evidence of bone loss, but it's localized. You have maybe 1 to 3 teeth in a quadrant, and maybe it could be one quadrant, and maybe it's two quadrants of 2 quadrants with 2 different, 5mm pockets with bone loss. So at that point, you're doing 2 quads of 43-42, placing any antimicrobial agent of your choice, your doctor partner, doctor owner, and your collaboration of choice of product, doing irrigation, and then you bring them back. And if it's, 1 quad, typically we'll do a cleaning. If it's 2 or more quads, we'll bring them back for periodontal maintenance, also do irrigation, and then reassess to see if we need to apply more antimicrobial agent in there. And then also, do they have decalcification? What is their Canberra level of caries? Are they low, moderate, or high? So then we recommend, a take-home product of Floridex, the 1.1 Nutrafluoride. If it's more severe, they have more sensitivity, a lot of inflammation, we may recommend the 0.63 stannous fluoride for 2 weeks. And then when they come back for perio maintenance, then they get on the stannous the stannous fluoride for another 2 weeks, and then go back to the 1.1 sodium fluoride. The Zen CP Plus, again, is for the higher levels of sensitivity and for whitening reversal. For spot reversal. So this just gives you an example. Again, this isn't anything that, everybody's following. This is just something I continually use, update, and implement through my practices. Everybody should, get together with your hygiene leaders, your hygiene teams, and figure out, what type of guidelines you want to implement, what products are you using, or what products will you be using as part of your periodontal guideline. So why do we need these? Like, what is the importance of having all of this, right? So especially with, why is it necessary to have a clinical foundation in your organization? Why am I stressing so much importance? And, when asked to talk about a topic, this is my go-to. This is the one thing, like if every organization had this in their company and their DSO, patients would be getting a lot more care and treatment planning, and doctors would be doing a lot more restorative work as well as cosmetic, right? But it's not about that as well. It's also our responsibilities. We're healthcare providers, right? We're here to take care of the patient and make sure they're getting a full comprehensive exam. Now, they may not agree to the full treatment plan, but at least we feel good. We can sleep at night knowing that we let that patient know everything that we have in our toolkit to provide that highest standard of care for that patient. And then also as a DSO, it is our responsibility to protect our providers. It is our responsibility to make sure that our dentists and our hygienists are morally doing everything right that they can, but we're protecting their liability by making sure the team around them is doing everything right as well. I mean, that is our responsibility. These hygienists, the doctors, they're trusting us to ensure that we have the proper platforms in place, that we have the proper people in place, that we have provided them with the proper training, and we're holding accountability, right? So let's just talk about what are some of the liabilities of doctors and hygienists. What are the top 4 reasons why hygienists get sued? So number 1, failure to update medical history and obtain signatures. Again, we touched on that as our number 1 parameter for comprehensive care. Failure to detect oral pathology, document and track referrals. Again, it was another one of our parameters to ensure that you may not have the oral cancer screening devices, nor should you rely on that, but you need to be making sure that you are doing a full soft and hard tissue exam and documenting your findings in their chart, and referring out when you do see something that is not normal, or if you have an in-house periodontist or oral surgeon, getting a biopsy of that area. Failure to detect periodontal disease. So although we are operating under the doctor's licenses, we still can get sued for these items. We're a supplement to the doctor, right? We're a direct hand to the doctor. So it is our responsibility to ensure that we are doing a proper assessment on all of our doctor's patients. So full mouth periodontal charting needs to be done, on all our patients, not a periodontal screening and recording. I was in shock to find out that still some people are using that methodology. Injury to a patient, as much as we don't want to, believe that one or feel that that would be one, it sure is when we don't have the proper armamentarium, when our hygienists are using scalers that have had, their tips retipped 3 times because we don't want to buy them a new instrument. So that's important to make sure that our instruments are always sharp, but they're always, up to date and durable, and to prevent this, to prevent injury to our patients. What are the top 5 negligences of dentists? So extractions, where they've had, some ramifications from a extraction. Endodontic procedures that have gone wrong. Dental implants is kind of a twofold. So it's not implementing as part of like a treatment plan. So if they have a missing tooth and the 2 teeth beside the missing tooth are virgin teeth, and we can put a dental implant. So it's, not recommending and not putting it in the treatment plan, but then also failure of dental implants, substandard crown and bridge, and then perio disease. Again, this is why I can't stress how important it is to have a perio protocol guideline in your DSO, or if you're a single practice in your practice. Failure to diagnose and treat in a timely fashion, and it's the lack of proper routine x-rays and periodontal probings that were just randomly recorded or never recorded, right? So all important things that we talked about and Rachel talked about as well. So how do you prevent that? How do we protect our providers? What is it that we can do as, DSO owners, DSO leaders? What can we do to help protect our doctors and our hygienists? The easiest, simplest thing is to put a quality assurance program. It's simple, it's easy to do. The hardest thing is keeping up with it, right? It's you can incorporate it into like a routine, a monthly or quarterly, however you want to do it, but just you have to stay on top of it. You have to hold yourself as an owner, as a leader, accountable to ensuring that it is getting done, right? So let's dive into our hygiene department. So, and we'll come back to the quality assurance. So hygiene department. So what do you think the benefits of, creating or emphasizing a hygiene department? I like to look at the hygiene department, like as a business within a business, right? So, it's one thing to have your periodontal guidelines in place, but how do you institute it? How do you implement it? How do you, get it to roll out to the rest of the organization, right? And having a hygiene guideline or a periodontal guideline is just one piece of it, right? The biggest part of it comes with, getting your hygienist to understand that they're not just tooth cleaners. We're a periodontal therapist. We are a big part of the business. So, empower your hygienist. Allow them to collaborate on the ideas that they have to improve, their office or their organization or their region. What is it that we can do to help empower our hygienists? And the easiest thing is include them. Just include your hygienist, get their feedback, survey them, allow them to help, make decisions on products. I did before blind studies with, fluoride. You distribute fluoride samples. If you can't make a decision which fluoride's the best and you want to get your hygienist buy-in, distribute different fluorides and have them pick, A, B, or C, and whichever one they go with, that's what you go with as you're on your protocol, on your formulary. Leadership. It's important to provide, having CE courses on perio is awesome. We need it, right? It's something we need. But what are the wants, right? The wants is a leadership. Providing leadership, continuing education, leadership books, things like that to take your hygienist to that next level is a key to not only taking the hygienist from being an employee to a career. This is our career. This is what we went to school for. We want to be able to impact our patients more profoundly than just doing a cleaning, right? So providing them with that leadership will only help you as well. Hygienists taking ownership and accountability. It's when they own their department and they feel empowered to have a business within a business, you will see the paradigm shift with the ownership of the schedules, the ReCare program, the confirmation, the doctor schedules. The more that we can get the doctors and hygienists collaborating on treatment planning and case presentation, the more treatment plans are going to come out of it, right? The more the hygienist is going to feel comfortable and confident talking to the patients about what he or she is seeing. What is the prognosis? What is the diagnosis? The more that we can educate and empower our hygienists, the more our practice will grow, not only with hygiene, but with restorative as well. And also, ultimately, you're giving patients what they want. The patients want better cosmetic treatment. They want to get their mouths healthy. And after learning everything that I know I'm scared after all the systemic links with perio, and I want to make sure I'm taking care of all of that, especially with everything, as a global pandemic that we're going through, patients are more conscientious of their health than ever. Performance is basically just, a barometer to see what improvement, where do we need to improve, not only personally as hygienists, but our practice, our region. I love the DSO atmosphere. It's just, I've been passionate about it again since I was 15 years old. I just love looking at numbers and, seeing, where am I in the hygiene performance this month? What are my metrics? But you know what? It's so much more than that, right? You can measure performance on so many different levels and so many different ways. I mean, treatment plan follow through, time management. Time management is huge. I recommend everyone to do time motion studies. Time motion studies is having, an outsider person come in and kind of assess the practice flow, the new patient flow, ReCare flow. What are we taking time on? How long is it taking us to take a new patient through a complete cycle of all of the different parameters that we're implementing? Where can we improve? Where can we shave off some, minutes and seconds? And it adds up. It really does. It really adds up, and it's just a really nice thing to see. And as a healthcare provider, I would want to know, how am I performing? Not just number-wise, right? It's many different avenues. Hygiene retention, having your ReCare patients, your schedules full, I mean, that's a barometer of performance right there. That goes to show how loyal your patients are to you, how well you are you're treating your patients and clinically assessing them and giving them value to that appointment, that they know they are pre-booking that appointment today and they're not missing it, because they know they cannot get another appointment with Rachel for 3 months. So they are going to make that appointment, right? So these are just, again, just some high-level areas I wanted to touch on. When you are defining your hygiene department, these are the things to look at. And again, always go back to people come first. You have to have the right people on board, people that are going to make a difference and take the practice to the next level. All right. So some examples I wanted to include for clinical SOP. So we have, a Floridex SOP. So it kind of just gives, again, hygienists like black and white. We like clarity. We need to know, why are we using this project? What is the purpose? When do we use it? And how much does it cost, right? So having a product SOPs is considered, a foundation, a platform. The next one is a perio restore, as we talked about earlier. We have that SOP. Regulatory compliance, again, having some type of SOP for your COVID-19. How do you want your teams clinically? I do have for administrative as well. And we have everyone sign off, and it's refreshed. Every month we do a refresher to ensure that everyone's following these guidelines. It's not only, to protect our patients ultimately, but our teams. We have to protect each other. We have to protect our families that we go home to, right? So we need to ensure that we have some type of guidelines in place. Performance measures. Again, as we discussed, there's so many different ones. I mean, this is just to name, a handful, or 10, I guess, of performance measures. And these have been proven to increase productivity. Time and time again, I can't, emphasize, this has proven to work. I've done it in, 3 organizations now over the last 20 years. So budgets for supplies, revenues for benchmarks, wages to hygiene revenue to practice revenue, hygiene production per hour, perio to pro fee. Again, going back to Rachel's presentation, the prevalence of patients having periodontal disease is greater than what we're, basically assessing. So kind of looking at, what are your perio procedures? What is that ratio between the perio procedures to your overall procedures? Where do you fall with that? Product revenue. Product revenue can be measured many different ways. Like you can measure it by per hour, you can measure it per day, you can measure it overall per month. Different ways to do that. Pre-booking is a metric to ensure that patients are being pre-booked at the time of their visit. There should be no reason a patient is leaving without an appointment. Chair utilization, you can get fancy and do one of these. Chair utilization dollars per operatory. Done that before when I was at Dental One, and it was pretty cool. But that's getting really fancy there. Templates and schedules, again, creating, seeing what your new patient lag time is and making sure that your, schedules allow for those new patients to get in a timely fashion, and your scalings. All right, so what are some of the high-level metrics that you can, extrapolate from that wheel and then put into like best practices, right? So these not only elevate your practice and increase profitability, but they also increase your DSO valuation for your organization. And that's, ultimately you're always striving to do that, right? So whether you're keeping your DSO as a legacy or, whatever your future goals are with it, these add value no matter how or which way you look at things. Hygiene revenue, you should be looking at having it at least be 30% or above of total revenue. Hygiene wages of 30% or less of hygiene revenue. Hygiene wages of 7 to 8% of your total revenue. So going back to the hygiene wages of 30% of hygiene revenue, so if your revenue is $30,000 per month in hygiene procedures, you wouldn't want your hygiene wages to be more than $9,000. Hygiene wages of 7 to 8 of total revenue. If you're at, $100,000 total with GD, perio, whatever specialties you may have incorporated into your DSO, you want it to fall between the 7 and 8%. Perio percent, the very minimum 30% or more, of all procedures should, be some type of perio. Again, anything with the 4,000 number, like 4346, 4342, 4910, 4341, those should all be lumped into that perio percent. Full hygiene schedules, again, just discussing retention, the importance of, pre-booking your patients and creating that loyalty with your patients. Pre-booking should be 85% or higher. If you have single column hygienists, they should be operating at a 150 per hour level. If they're assisted, it'd be 225 or above. And again, whether you're a PPO or your Medicaid environment, these should all be applicable to both environments, especially because of the fact that perio is being covered in the Ohio state, or for Ohio anyways. You would have to check your different state guidelines, but in the state of Ohio, I'm sorry, I should have referenced that earlier, more perio procedures are being covered. The bottom line to this is kind of just showing you guys that when you increase, as long as your wages are in alignment, right? Of course, that comes first, but as long as your wages are in alignment, ultimately, the bottom line is a direct correlation. Your profitability is directly correlated to your hygiene production. So just keep that in mind when you are evaluating your metrics of your organization. The next slide is we're going to talk about quality assurance a little bit more. So how do we hold accountability to the systems, right? Rachel mentioned chart audits, so that's exactly what I have portrayed here, actually. I still find it amazing that we never met each other prior to this symposium, and yet we had a lot of alignments in our guidelines here. And so holding accountability, one way to do it is a chart audit. So this is an example of just a basic chart audit of a new patient ReCare exam. Now you can do more chart audits kind of around like certain procedures. So for general dentistry, but for hygiene, this is a starting point anyways, to ensure that your new patients and your ReCare patients are coming through, they're getting their medical history signed, they're getting blood pressure readings, they're getting comprehensive care versus limited. If they are getting a limited exam, there's a note section. They need to describe why are they, why did they get a limited exam? It should be in the chart. X-rays, what type of X-rays did they receive? Did we do full mouth periodontal charting, or did we just say, you know, next visit, or not do it at all and charge out a comprehensive exam? Did we chart existing? Did we chart restorative treatment needed? Also, when you're checking for restorative, if there's an opportunity for an implant, was it discussed in the chart, in the progress notes, and was it treatment plan in the charting? The next one is treatment plan. Was that accepted? Was it signed by the patient? The next one, I'm sorry, is accepted or denied. You know, accepted meaning, did they pay something towards that treatment plan, or did we just schedule them? Did we offer payment options? I think Rachel alluded to this earlier as well. Are we flexible with our financial options to our patients? Did we offer care credit, for example? I think there's a couple more out there now. Ally is another one that's out there. Same day treatment. So did we start something today, or did we just do a great happy visit exam, you know, got all of our diagnostics, and, you know, schedule the patient to come back? Sometimes we don't have opportunity to start same day, but I'm a firm believer that when I worked chair side and I ran 3 chairs at a time, I never got out of my chair until my next patient was physically ready for me, meaning they were ready for me to get in there and do a perio chart. All their x-rays were taken and medical history reviewed, you know, things like that. But again, I had a hygiene assistant, which was very helpful. But anyhow, you know, if you have an opportunity to start that day, please do, especially when it's non-surgical periodontal therapy and we are stressing the urgency. So your sense of urgency should be to start that quadrant. At least do 1 quadrant for that patient, and they will see and feel the difference between that quadrant that you have subgingivally scaled, root plane and scaled, compared to the rest of their mouth. And then did we schedule them for their next visit for restorative? Did we schedule them for their next visit of hygiene? Sometimes restorative is not applicable, but, you know, if it is, did we schedule them back?